What's up, everybody? My name is Dr. Zach Guiser, and this is another entry into the Athlete Development Journal, where we take complex athletic problems and provide simple solutions.
Yeah, straight A student, but I'm friends with the cool kids. Following the rules and the rubric. Freestyle on the bus.
Hines Ward was known for two things: his infectious smile and his killer instinct. He would lower his shoulder, nearly put a defender into a coma, and beam his pearly whites throughout the whole thing. He was an insanely tough dude who loved the game. In the 2009 AFC Championship game, however, Hines suffered an injury that even he couldn't tough out. He had to come out of the game in the first quarter with an MCL injury. Just 2 weeks later, though, he made a big splash by coming back and playing an important role in the Super Bowl. He attributed his rapid return to a new-ish treatment he received called Platelet-Rich Plasma Injections, or PRP for short. The New York Times grabbed a hold of that, ran an article, and thrust PRP into the mainstream spotlight. Its use cases have evolved over the years. Professional pitchers inject it to heal partially torn UCLs, recreational adult athletes inject it to heal their arthritic knees, and Kim Kardashian even injects it all over her face to get rid of her wrinkles, which is not a joke. Seriously, it's called a vampire facial, and it is strange. Today, however, it remains a hot topic. Many patients and physicians swear by it. They say it's a miracle worker, it does amazing things. But insurances don't believe enough in its efficacy to pay for the treatment. So let's find out. What does the science say about PRP? Okay, our two main questions here today are: number one, is PRP effective at improving pain and function? Number two, is PRP safe? Before we answer those, before we get to the outcomes, we need to establish some background knowledge on the physiology. There are four main ingredients of your blood. You got plasma, which makes up 55% of your blood, red blood cells, which make up 44% of your blood. Those are also called erythrocytes. White blood cells, which are also called leukocytes, which make up less than 1% of your blood, and platelets, which is an important part of platelet-rich plasma, which are also called thrombocytes, that make up less than 1% of your blood. Platelets are crucial at jumpstarting your body's internal repair system, but they make up less than 1% of your total blood volume. So the goal of PRP is to try to reconfigure the proportions of your blood ingredients to dose in a boatload of platelets. Here's the process. First, someone takes a blood draw from you. Then the blood is spun in a centrifuge. The fast rotation of the centrifuge separates your blood ingredients into different layers because they have different weights. However, white blood cells and platelets have similar densities, so you have to use a double spin method if you want to separate those. The platelets and plasma, and sometimes the white blood cells, depending on the type of PRP injection you get, they're recombined and injected back into your injured area. Once the injection happens, the platelets are activated and release specialized proteins called growth factors that jumpstart healing. There are over 30 bioactive proteins in platelets, but the big five we're really concerned about are: number one, platelet-derived growth factor, which we can think of as the project manager. Its big thing is it's going to recruit other cells to the area and tell them to start multiplying. So that's the manager of this whole thing. It's kind of the boss that's telling other people what to do, other cells what to do. The second one is transforming growth factor, which is kind of like the mason in this construction project. It builds the scaffolding. It stimulates the production of collagen and helps create the matrix for new bone and cartilage to grow on. So it's laying some foundation. It's laying some scaffolding. It's kind of laying the bricks, which is why it's called the mason. The third one is the vascular endothelial growth factor, which is kind of like the electrician or the plumber. It creates new blood vessels through a process called angiogenesis to bring in oxygen and nutrients. So you can think about that as bringing in the pipes. It's laying all the pipes that can bring in all the oxygen and nutrients, which is why we think about that as the electrician or the plumber. The fourth one is epidermal growth factor. This is the finisher. So this speeds up the growth of skin cells and helps wounds close up and heal from the outside in. So this is going to get everything closed up. It's going to close the skin. And number five is the insulin-like growth factor, or the general contractor. So this works in almost every type of tissue in the body to ensure that local cells are healthy enough to handle the rapid repair process. So it has a host of roles and it does a bunch of different things. Okay, so we've got all of those different growth factors, or the things that are supposed to help with the healing involved in PRP. So let me summarize that whole thing. You have platelets, which are really important for healing and jumpstarting your internal repair processes. If you take out your blood and then you re-inject it where you have a high density of platelets, then the hope is that we can jumpstart that internal repair process by having all of those growth factors start doing their jobs in a particular order. Okay. PRP is a part of a category called orthobiologics, which is the use of naturally occurring biological substances to help injuries of the bones, joints, muscles, and tendons heal faster and more effectively. It sounds great, right? Using your own body's natural biological material to heal yourself sure sounds like a win to me. But that theory is cool and all. First, we have to see if it actually works. Okay, so that's the underlying physiological theory. Now we have to see, what does the science say? What do the studies say about actual outcomes? Now remember, our two main questions today are: number one, is PRP effective at improving pain and function? And number two, is PRP safe? To answer those two questions, I have four studies for us to work through. Then at the end, we're going to form a cohesive narrative and now give my current stance on all of this. If you don't care too much about the nitty-gritty details and you just want the answer, you can jump straight to the takeaways section we have labeled in the podcast details. However, I did change the method this time. We're going with 10 bullet points or less for each study to summarize just the most important things. The first study we have, a systematic review of platelet-rich plasma for low back pain. So we're concerned about low back pain. This is from 2023. This was the beefiest systematic review on PRP for low back pain that I could find. It consisted of 13 randomized control trials and 27 case series studies. Remember, randomized control trials are the highest quality individual study we could have. A systematic review is a very high quality overall summary of all these different studies combined. However, something about this study just rubs me the wrong way. They don't report significance values for the individual studies, which I find very odd. They don't report effect sizes or anything like that. It just feels like they're hiding some stuff. Not saying they are, but it feels like we're not getting the full picture from this study. The third bullet point, most of the studies were on intradiscal PRP injections, and they found significantly greater improvements in pain, function, and satisfaction than placebo. The improvements were maintained for, and I quote, many years after treatment. So that's whenever they're injecting the PRP into the disc, intradiscal. The fourth bullet point, similar improvements were found in both epidural injections and facet injection. Okay, so we're seeing some progress here. Number 5, it seems that higher platelet concentrations were associated with higher initial pain after the injection, but it did lead to larger improvements in pain, function, and satisfaction in the long run. Interestingly, there was evidence to suggest that platelet-rich fibrin, or PRF, may be more effective for discogenic low back pain than PRP. So that's something to keep an eye on in the future. Bullet point number 7, in all the studies, there were no complications such as progressive disc herniation or neurological deficits. There was disc space infection reported in only one study. Number 8, the preparation and types of PRP used were so diverse and absolutely all over the place. Number 9, and this is an important one for me, there's a surprising dearth of data. And this is a quote from the study itself. The use of platelet concentrates in surgical practice was first reported in the 1990s, while the use of PRP for spinal pathologies has been described for over a decade. However, in more than 10 years, only 13 randomized control trials with limited patient samples and a few dozen case series have been conducted, predominantly derived from the author's clinical practices. What that means is, I don't know why we don't have more studies about this. It's surprising with how prevalent PRP is and how much of a debate it is that we don't have more high quality randomized control trials out there for low back pain and PRP. Okay, my main takeaways from the study: PRP is quite promising for low back pain, but the statistical significance for individual studies not being shown is a yellow flag. Furthermore, it appears really important to make sure the preparation of the PRP is appropriate, and we should investigate PRF further in the future. This study was a good starting point, but I'd still like to know more about what the research says about PRP and low back pain. So let's cue up the next study. The next study is called Platelet-Rich Plasma Treatment for Lumbar Spine, a review and discussion of existing gaps from 2024. Bullet point number 1, this is a high quality narrative review, not a systematic review, a narrative review. So a narrative review doesn't have a pre-planned systemized search strategy, so it's not reproducible like a systematic review is, and it's more subject to bias. However, this narrative review is thorough and descriptive. It does its job. Number 2, a couple of single-arm trials, which means there's no control group, found some positive results. But those studies must be taken with a strong asterisk. There's no control group. It's a single-arm trial. So how can we know if the 14% success at 1 month to 47% success at 6 months was due to the PRP injection or just the natural healing power of time? That's why a control group in an experimental study is so important. Number 3, that's where randomized control trials come in. The randomized control trials showed mixed results, and some found statistically significant improvements, while some showed no difference, and some showed improvements that weren't statistically significant. It was kind of a hodgepodge all over the place. Number 4, all the randomized control trials had small sample sizes. Okay. Number 5, one RCT on facet joint injections found that corticosteroid injections were more effective at 1 month, but PRP was more effective at the 3 and 6 month marks. This again suggests that PRP might be something that works better over time. Number 6, importantly, a couple of different studies in different categories showed that higher concentrations outperformed lower concentrations. So my takeaways from this study, PRP seems to be more effective over time, more effective with higher concentrations, and it is in need of standardization of preparation and evaluation. Okay, so I feel like I have a good handle on what the evidence says about PRP in low back pain at this time. What about other areas of the body? Let's cue up the next study. Okay, the third study is platelet-rich plasma injections in the treatment of patellar tendinopathy, a systematic review and meta-analysis from 2022. Okay, so we're looking at patellar tendinopathy, that's knee pain, jumper's knee, very common in our athletic population, our young jumping athletes. Number 1, this is a solid systematic review. I like this one. They did a good job. Number 2, PRP for patellar tendinopathy did not have significantly better results than non-PRP injection, saline injection, dry needling, stem cell injection, hyaluronic acid injection, high volume injection, or no injection. So let me run that back. All those different things, PRP for patellar tendinopathy did not have significantly better results. Number 3, the only thing it outperformed was extracorporeal shockwave therapy, and that was only one study, I believe, and so you can't really consider that to be a review. Number 4, importantly, though, there were no safety issues outside of temporarily increased localized pain. Really important. We're talking about safety. Number 5, also importantly, the study doesn't segment out and analyze the different categories of PRP. Number 6, I've got some concerns here. This study is supposed to be strictly about patellar tendinopathy. The world's leading tendon researchers tell us that patellar tendinopathy is an issue that is often misdiagnosed. People get diagnosed with patellar tendinopathy, but it's actually something else. Their rule is if you're not an explosive young jumping athlete, it's most likely not patellar tendinopathy. The average ages in this study were awfully old for true patellar tendinopathy. We're talking most people in the study were in their 40s and 50s, and it's really hard to get true patellar tendinopathy whenever you're in that age. So there might be some issues here. Okay, my takeaways from the study. PRP as a general entity might be unhelpful for patellar tendinopathy. However, this study does not parse out different subtypes of PRP at all, which is important. Every study is alluding to the same thing. All of these PRP injection factors are different. As one study that I read but didn't make the cut to be reviewed in this entry so eloquently said, standardization of these factors is essential to maximizing its clinical blessings. Okay. We have to have some standardization here to understand what's going on with each of these injections. PRP is not PRP based on all of these different factors that can be different. Now I'm going to run through these factors in this next study. Our fourth study, reevaluating platelet-rich plasma dosing strategies in sports medicine. The role of the 10 billion platelet dose in optimizing therapeutic outcomes, a narrative review. This is from 2025. Number 1, bullet point number 1. This is again a high quality narrative review, not a systematic review, narrative review. It does its job though. Number 2, a systematic review by Berrigan et al. Analyzed 29 randomized control trials and found 90% of studies with doses greater than 5.5 billion platelets reported significant clinical improvements, while studies with less than 2.3 billion platelets failed to demonstrate therapeutic benefits. And this is a p-value of less than 0.1, so it was significant. Okay, let me run that back. 90% of studies with doses over 5.5 billion platelets did a good job. Studies less than 2.3 billion platelets did not do a good job. Seems important. Number 3, the review identified an ideal cumulative dose of 10 billion platelets across multiple injections for optimal efficacy. This suggests clinicians should aim for a minimum dose of 4 billion platelets per injection and a cumulative dose of 10 billion platelets across multiple treatments. Bullet point number 4, rotator cuff tendinopathy, lateral epicondylitis, gluteal tendinopathy, Achilles tendinopathy, and plantar fasciitis all found that positive benefits with PRP, especially with platelet counts between 5 to 10 billion. Bullet point number 5, new data suggests that leukocyte-poor PRP may provide more pain relief than leukocyte-rich PRP. So leukocytes are white blood cells. White blood cells can increase inflammation, which can negate some of the benefits of PRP. So if you have leukocyte-poor PRP, you have a low amount of white blood cells in there, it may be more beneficial for certain use cases than leukocyte-rich PRP. That goes back to the beginning where we talk about leukocytes, white blood cells, and platelets have similar densities. So if you want to separate those ones out, you have to do a double spin method in order to have separation between the platelets and the leukocytes. But that takes us to bullet point number 6. Not all leukocytes function similarly. Neutrophils are one type of leukocyte, or one type of white blood cell. Neutrophils are highly inflammatory and may promote pro-inflammatory and catabolic effects, potentially detrimental to tissue healing. Monocytes and macrophages are different types of leukocytes, different types of white blood cells, but they, on the other hand, may promote pro-reparative properties and play a key role in tissue regeneration. There's some experimental stuff where they're putting monocytes in but taking neutrophils out. So that could be something to look forward to in the future. Bullet point number 7, there is a consensus that red blood cell contamination should be minimized. Unlike platelets and leukocytes, red blood cells do not contribute to tissue regeneration and may be detrimental to musculoskeletal tissue. So where there's debate about what platelet count you should have, or whether you should be leukocyte-rich or leukocyte-poor or monocyte heavy or whatever it may be, there's consensus when it comes to red blood cells. We don't want them in there. Bullet point number 8, endogenously activated PRP seems to perform better than exogenously activated PRP. So that means if it's activated once it's inside your body by those natural processes, that seems to perform better than if you activate it before the injection is injected into you. My takeaway from the study is short and sweet. All PRP is not created equal. So we've worked through the story, we've worked through the science, and now we're on the takeaways. For those of you who are just joining us again, who skipped forward to this part, welcome back. What's actually important here? Number 1, we have some reason to believe that PRP is more effective at reducing pain and improving function than placebo or cortisone. Number 2, we have little to no reason to believe that PRP is unsafe. Number 3, we have strong reason to believe that all PRP is not created equally. So my stance on the question, is PRP a safe and effective treatment? If someone has rigorously modified their workload with a skilled physical therapist, has gone through a prolonged exercise and manual therapy rehab program with a skilled physical therapist, and has still not had relief from their pain, then PRP is worth a shot. The current evidence suggests that the type of PRP that is most effective has the following characteristics: a high platelet dose of 5 to 10 billion platelets per injection, a high cumulative dose of greater than 10 billion platelets over multiple injections, leukocyte-poor PRP to reduce inflammation and tissue degeneration, minimal red blood cell contamination, and endogenous activation. Okay? So you want to look for high dose of platelets between 5 to 10 billion per injection, over 10 billion over multiple injections, leukocyte-poor PRP, no red blood cell contamination, and endogenous activation. All right, so let's give this a grading. To give clarity about how strong the current evidence is, I use these 5 categories to grade the interventions we discuss. If something is proven, that means the intervention is supported by robust, reproducible human data where the probability of them being ineffective is near 0. If something is promising, that means the treatment is backed by strong mechanistic logic, animal data, or early human data that looks effective but lacking definitive long-term trials. If something is fuzzy, this is an intervention where the data is inconsistent, contradictory, or confusing, making it currently impossible to determine clear benefit or harm. If something is noisy, it's a hyped-up intervention where the signal is too weak to form a conclusion because the evidence relies mainly on anecdotes, theory, or low-quality studies. And if something is nonsense, this is something that has been rigorously tested and proven not to work despite continued popularity and marketing. With all of that, I'd say that PRP is in the promising category. So this is a treatment backed by strong mechanistic logic. It's got early human data, it looks effective, but lacks definitive long-term human trials. I would be between promising and fuzzy at this point with this one, but I think there's enough evidence that shows benefit, shows statistical significance, that it looks promising. We just need some standardization of the different characteristics of PRP before we can consider moving it up in the hierarchy. All right, now let's wrap it up with a couple important things. Number 1, this newsletter and podcast is completely free. I spend many hours each week researching, writing, illustrating, recording, editing, and uploading. The best way you can support it and allow it to continue is to share it with people you know. Please share this podcast episode with somebody today. Please, please, please. Number 2, everything in these newsletters, podcasts, and social media and on our website is for educational purposes only and should not be taken as medical advice for you or your athlete. Please consult directly with a healthcare professional. Thank you so much for your help in spreading the word about athlete development. And until next time, go be great out there.
Yeah, straight A student, but I'm friends with the cool kids. Following the rules and the rubric. Freestyle on the bus and it's too lit.